Hi, everybody. So I am Diane McKee. I'm the director of the Nice Ring Practice-Based Research Network, and it is my privilege to welcome you all. It's really great to see so many people. A few of you that I see once a year at this event, but I see wonderful connections. I see students talking to community organizers, and I see pediatricians talking to dentists and all sorts of things. And I think that's one of the wonderful things about having this event every year is the opportunity to bring people together. For those of you who don't know what Nice Ring is a practice-based research network that we founded in 2003 out of the Department of Family and Social Medicine, which now includes 35 practices in the Bronx, Queens, Manhattan, and Westchester County. And our mission from the beginning has been to try to generate the evidence base to help us improve quality of care and health outcomes for the patients and the families that we serve. So to that end, we're thrilled that there's a lot of interest across the whole institution in trying to be a data-driven institution, and we feel that we are an integral part of trying to help do that. So that said, we are thrilled. We have absolutely worked Lloyd Michener to death today. He's been talking about the Institute for Clinical Translational Research. He's been talking with educators about how to incorporate population health into what we do in training programs. He's been all afternoon engaged in a workshop that many of you were participating in that was really talking about how we can collaborate together to address social determinants of health. So we're going to get one last hour out of him. I'm going to bring up Bruce Soloway, Vice Chair of the Department of Family and Social Medicine, to introduce him.
Good afternoon, everybody. Normally, this is Peter Selwyn's job, and unfortunately, he's on his way to or fortunately for those who will be attending the conference, he's off to lead. So for the first time in my memory, he's not here, and I'm pleased to be able to stand in for him and say some of the things I think that he has said at conferences like this in the past and that I'm pleased to reiterate. Nice Ring has been around for about 12 or 13 years. I recall going to one of the very early Nice Ring convocations about 10 or 11 years ago, which took place in the back room of an Italian restaurant on Williamsbridge Road. So we've come a long way since then, and it's always a pleasure to see this large gathering, and particularly to see the amazing collection of work that's on display in the hall across the corridor, and that everybody, I hope, will have an opportunity to partake of and really appreciate after we hear from Dr. Michener. This collection of work is really what this convocation is all about. It is a tremendous representation of what can be done in the context of primary care practices around New York City, where we are all, as all of us in the room who are clinicians know, extraordinarily busy, extraordinarily taxed. Many of us doing double duty as clinicians and educators, and then finding the time to be inquisitive and curious and rigorous and methodical, and to gather data and to create new information and share new knowledge as we go about our daily work. And what makes this even more remarkable is that most of us are doing this with no dedicated funding, no protected time, just the will and the determination to push forward and to really document and clarify and improve what it is we're doing and share that knowledge with others. So it's tremendous. Just to walk through that hall of posters really says a tremendous amount about the people who are gathered here today and about what we all are dedicated to as family physicians and primary care doctors and all the other disciplines, I think, that are represented here today. So really, I think we should start with a round of applause for everybody who's contributed to this. One of the things that we always see from these posters is the scope of the work that we do, and Diane and Claudia have been kind enough to list out the topics for us in the front of the program, and it's always impressive how broad the work is and how many different areas we're working in: chronic disease, community health, health promotion, health systems, maternal and child health, reproductive health, mental health, resident and student education, screening and prevention, and really important work being done in all of those areas. What strikes me about looking at the representation of this particular group of posters is the focus on community. And it really aligns well with the direction that I think all of us are finding ourselves going in as the healthcare system as a whole begins to wake up to something we've been talking about for decades, which is the importance of the social determinants of health. And we now find ourselves with actually funding from the state through DSRIP and other mechanisms to develop community partnerships, broad coalitions of folks who are working not just within the walls of our clinical enterprises, but very much outside the walls and across organizations, where really a lot of what determines the health of communities really takes place. And you will see that represented in the posters. And just glancing through the program, we have posters and work represented on community health workers, home-based care, team development, community engagement, food sources, school health, housing, and a variety of other actually areas that I think some years ago we would have approached somewhat differently, but now we're approaching these as really part of the mainstream of what healthcare is starting to be all about. So I hope you'll pay attention to that as we go, and I think our speaker will help frame that for us. Dr. Michener is professor and chairman of the Department of Community and Family Medicine at Duke University Medical Center in Durham, North Carolina. And the Department of Family Medicine at Duke, for those of us who are sort of in the academic family medicine arena, we know the Department of Family Medicine at Duke is one of the really powerful and courageous innovators, both in clinical practice and in education and research, really pushing the envelope and challenging accepted wisdom, and really developing programs that have been a model for family medicine practice and education around the country. Dr. Michener has devoted most of his career to the interface between communities and academic health centers. He has worked on finding ways of making healthcare more effective through teams, community engagement, and practice redesign. And I think he'll tell you in much more graphic terms than I would even attempt to do what he's been working on. I would call your attention to one particular project that we've referenced a little bit today, and I think will be of help to many people in the audience, which is the Practical Playbook, which is a free web-based program of resources for people who are working exactly in that area of trying to connect clinical practice to community engagement. Many, many other things I could tell you about what Dr. Michener has done over the years, but I will leave that and give him the opportunity to tell you himself, not so much about what he's done, but about directions that we can go in together to make this broader vision of primary care with attention to social determinants of health a reality. So Dr. Michener, thank you. Pleasure to have you.
Thank you. Well, it's a real honor and pleasure to be here. I must say I've been a fan of NYC for a long time, and sometimes when you're a fan of something and you get to see it close up, you go, but having spent the day here and looked at what you're doing, I'm really a fan. I mean, I just think it's incredible. And it's really a pleasure to come join you and share some of the things we've been doing in Durham and then nationally that may be of value to you. I have four caveats. One, I need you to wave at me if you can't hear me. Normally I can be heard in a football stadium across, but we've been talking all day and my voice is starting to fade. So the reason I'm actually standing to the side is it's the best place to hold the mic. But if I drop off, please just wave. The other one is I'm going to be giving a talk about medicine, public health, and communities. And I'm going to mix together healthcare speak and public health speak. And you will be going along, I think, and think, oh yeah, I know about this. And then all of a sudden you're going, what in the world is that guy talking about? So if that happens, just wave your hand and we'll go back and try saying it another way, because the language of medicine, public health, and community are not the same. And we use language and images differently, and learning how to discuss issues across those boundaries has been much of the work we've been doing nationally for some time. The other is, I'm curious, how many of you are community members? Good, okay. How many of you are students or residents? Okay, so I'm gonna, just fair warning, I'm gonna talk for a bit and then I'm gonna also ask questions. I encourage you to ask questions, but I have some slides coming. And I've been using actually around the world. And I have a hypothesis, actually so far completely correct, which is the groups that get the slides correct are first the community members, second the students and residents, and with only one exception has it been somebody who actually teaches this stuff. So for your on-call guys, I'll ask you what's going on. In some cases we won't actually know, but we have some hypotheses. So please, I just wanted to know what the ante is. And please do ask questions. Again, I'll go for a couple of minutes and start asking questions, but if you're going, wait, this is crazy, I don't understand, interrupt. So first, my formal disclosure. Oops. We should push the button the right way. No. Actually, Paul, I'll let you change that. I have no disclosures. So just so you know, I'm going to be sharing data from a lot of federal agencies and national groups. That's all shared with permission, but the conclusions that I draw mine alone, please don't blame the people who gave us the slides. Whoops.
That's okay.
Okay. But the other one is that I have no financial interest to disclose, so anything I said is appropriately on my head. Okay, thank you. There we go.
Thank you, Claudia.
No problem. So first, for those of you who, I realize I'm in Trump land, but there actually is a conspiracy. There actually is a group meeting across the United States. It's federal. What, I couldn't have timed it better. There is a conspiracy, and they don't want it let out. Actually, we do want it let out. There's been a meeting going on for some years at the Pentagon of about 40 federal agencies, a few civilians, I'm one of those, to actually talk about changing the national dialogue from health care to health. To actually, I'm trusting you guys, it's okay. Okay, so to actually say, what would it like if we actually had healthy people and healthy communities? Could we even imagine it? And what would it take to get there? And what I want to share with you is some of the discussions that have been underway across those federal agencies and with the city community partners to actually map that path out. These are some of the partners we've been working with. I'm not sure you can see those from the back of the hall, but they're an interesting group: National Institute of Health, Centers for Disease Control and Prevention, Centers for Medicare and Medicaid Services. You kind of expect that perhaps. But there's some interesting ones. In fact, here comes my first question. Homeland Security is one of the groups that wants to talk, to be engaged with groups like you about improving health outcomes in our communities. Why would Homeland Security, but just to give context, I'm at the Pentagon, we're talking about all this work on community engagement, and a guy from Homeland Security says, Dr. Michener, we need to talk. I don't know about you, but I didn't find that particularly happy feeling. Why would Homeland Security care about healthy communities? Anybody? Okay, students, community members and students, here's your first chance.
Thank you. I think that Homeland Security might be curious in healthy communities, because if we don't have healthy communities, we might have, byproducts of people who want to be violent, or they may have access to certain weapons and they don't really need it. And
that's, got it. So it turns out that in the United States, one of the causes of domestic terrorist cells is when somebody's feels like a marginalized member of a community and they lose someone, a family member, because of something that could have been prevented, and they'll tip them over. So Homeland Security is interested. Let's take another one, Federal Reserve Bank. The reason for that is because actually the pattern of redlining in our communities, some of whom are not far from here, actually has left a long-term pattern of ill health. And it turns out improving health is actually part of the Federal Reserve Bank charter. So the Federal Reserve Banks have been getting interested in this. One more, Department of Defense. Really, in fact, they were hosting the meeting. Why would Department of Defense care about health? Let me make that a question. So far, the students 1 to 0, okay.
I'm also a student. Veterans Health.
So part of it is Veterans Health. And in fact, that is part of it. It's hard to have healthy veterans if you don't have healthy folks coming in. The other one is actually they're worried about the recruits themselves, or increasingly from rural and poor communities. So if you don't have healthy people coming in, you actually don't have healthy troops. But there's one more, and rather than ask you to guess that, it's because you can't have healthy troops if their families aren't healthy. And especially when they're deployed, if the folks who are deployed have to worry about the health of their loved ones back home, that's a security issue. That is an issue for the Department of Defense. So there's actually a healthy bases program in the Department of Defense to really see what the DoD can do to help domestic communities help be healthy. And they're looking for partners on that. So a lot of agencies, 40 some actually in all told, and they're sending a message. And don't try to read all this, I'll go through it. But the point is that for healthcare groups is stop, road ends, all traffic leave here, because we're going to change how we deliver healthcare. And the federal agencies are coming together, led by Centers for Medicare and Medicaid Services, say, we're going to make a change. We're going to pivot and actually look at what it would take to actually be healthy people and healthy communities. Let's take CMS, Centers for Medicaid Services, the biggest payer in the world. This is something they wrote in January of 15. Bill Kassler is one of our partners with the playbook. We see, I'm going to read it to you. I know you can read, but the words here are really interesting. We see CMS as playing a catalytic role. Catalytic. By embedding population-based strategies in our programs and policies, CMS can help drive transformation that aligns healthcare systems with public health and social service systems, and thereby accelerate progress towards improved health for our whole country. That's CMS. By the way, we met with them and asked them how they see doing that, and they call it the spaghetti technique. You may know this one. I realize I'm in the Bronx. You throw the spaghetti on the wall and you see what sticks. It's literally how their approach is. Let's try things, because it's not real clear even on a theoretical level what would work. We're just going to try things and see what works. Accountable Health Communities, national program that's rolling out, and there'll be, I think, another wave of that shortly. Really looking at how CMS can support work in communities addressing social needs through Medicare and Medicaid with on. CDC, how many of you have seen this slide, by the way? Just curious. Not very many. So CDC, actually, let me say this twice. CDC partnered with Internal Revenue Service. Now, there is a match made in heaven. So CDC partnered with Internal Revenue Service to rewrite the tax code for nonprofit hospitals and health systems to mandate that nonprofit hospitals and health systems, unless they're public, actually engage with their local community, their health department, participate in a community needs assessment, gather data, implement plans, and disseminate those publicly. And they quickly realized that hospitals and health systems, with some exceptions like where we are, actually didn't know how to do that. So now this is the next part, they wrote a game. CDC wrote a game called Meeting in a Box to help health systems learn how to engage with their community. Oops. And they're doing infographics. This is one of them, trying to make it simple for medical groups, saying, invest in your community, focus on the area of greatest need, collaborate with others, look at socioeconomic factors, physical environment, health behaviors, clinical care, because that's what it's going to take to have healthy people and healthy communities. And the group they want doing this the most are hospitals and health systems and primary care. So part of the reason I wanted to come up here is to say the big primary care networks have a major role in this larger initiative, and we're often finding hospitals and health systems funding startup projects around primary care because of this new IRS mandate. Then here's the newest one. It's called 618. It's a program to take evidence-based interventions that work in populations and get them out to hospitals and health systems, but also payers. So Blue Cross Blue Shield of North Carolina, for instance, is one of the target groups. We're saying, here's evidence of what works. Things like tobacco cessation, exercise programs. Here are things that work. Six high-burden health conditions, 18 evidence-based interventions. And we want to get them out there. And we particularly want to get them out to groups that are doing things like DSRIP. Primary care groups are looking at medical home implementations, because these are parallel programs you can use that have demonstrated efficacy in improving health outcomes and often saving money. So 618. But the real action is on the state level. I mean, there's a lot of federal work, but the this is a slide from National Academy for State Health Policy that I swiped for permission, saying we're going to change how we deliver care. And you guys are in one of those models. Actually, you're in a couple of them. Really reorganizing care delivery for efficiency, equality, and encouraging teamwork, linking providers and resources and communities. And that's being driven by the governors and the Medicaid associations in large part. By the way, the states do get together once a year and they trade stories. So Oregon will talk to Washington, we'll talk to Illinois, we'll talk to Louisiana about what's worked. So they actually swap stories. About 1,000 folks, if you can imagine that, usually 2 doctors. Actually talking stories about what works and how do we redesign care to get better outcomes. Let me stop there. Last year they had a couple sessions simply on what they wanted primary care to do. And by the way, they used primary care, but in many states it's largely family medicine or predominantly family medicine. What's the major thing that states want primary care and family medicine individually and collectively to do better or do differently? Anybody care to guess? Actually, I'll give you 2. There are 2 top of mind issues for the states for primary care redesign. And I'll give you a clue, you're dealing with one and not yet that I know of the other. How about any family docs want to take that one on? What are if you could improve health outcomes by something you did in the office, what would you tackle? Office-based. There we go. A brave soul. End-of-life care. Oh, that's a good one, and that's not on the list. Oh, it's a good, I like that one. Yeah, no, think about what you read in the newspapers that's healthcare related. What's driving the governors, the Medicaid directors nuts?
Oh, since you said that, then I have to change my answer.
No.
I was going to say smoking cessation, but I guess that's not what you were thinking. I'm not sure.
Okay, we'll do one more now. By the way, I didn't guess it, and some of my family medicine colleagues are not happy with the answer.
Integrating mental health with primary care.
Number 1, you win. Yes. Number 1 is integrating primary care with mental health and finding effective ways to do that. And there are a lot of discussion. Number 2 is actually there are 2 variations. It's really dealing with opioid overuse and overdose. Opioid overuse and overdose is the other one. So substance abuse more broadly. So finding effective strategies, and the states are driving major change, including mandatory retraining of primary care groups to do that. So it's coming. So that, by the way, I've talked about the states. That's the current map of every CMS, CMMI, Centers for Medicare and Medicaid Innovation project in the U.S. Red means the whole state. It's over 60% of the U.S. population is engaged in an innovation project right now, all the states. So this idea that healthcare reform is something that's kind of coming, guys, it's here. It's underway. We're working out the details. It's moving fairly rapidly. And again, the groups are trading stories, examples of what learned. I'll share some of that. One of the things we're learning in this, by the way, is that it is a process. It's not, here's the right, do this and you'll be okay. It's actually a journey you have to take. You have to actually build capacity in the practice. You have to build capacity in the community. You have to do it together. It's not linear. It's more of a spiral where you have to decide to do something. You have to plan it. You actually have to do it. And I'm embarrassed to say it, but actually medical groups tend to fall flat there because we overplan and sometimes under-implement. And then you have to monitor. You have to know whether it actually made a difference. I'll talk about some of the metrics in a second. And then perhaps most telling of all, you actually have to celebrate when it works. That's sometimes something we forget to do, and our community partners remind us that it is a journey and we need to celebrate taking it together. And then you start over. So you do projects over and over. In Durham, North Carolina, we probably have 50 projects we do simultaneously right now with our community to improve health outcomes. The data matters. And I got Arthur Blank here to remind all this, but it's actually one of the things that has been real clear is it's not just the data that the medical groups care about. It's the data that the communities care about. So one of the things we've been working with several federal groups is trying to align the metrics around what things that what folks who live in the community actually think is important. To give an example, in my community, talking about hemoglobin A1C with, gets me a little bit of space, talking about amputations. In Durham, North Carolina, we haven't amputated a limb for diabetes from somebody who, other than somebody who's a minority race, in years. Why is that? What's going on that would make that so? So finding the metrics that matter and tracking them has been key. I said I'd share some slides that are questionable or raise questions. Have any of you seen this one? This is really causing some heartburn and headache. This is a map, obviously, of female mortality rates from 92, 96 to 2000 and 2006 by county. Red means they're getting worse. Blue means they're getting better. Half of the, for women. So female mortality rates in the U.S. in half the U.S. counties are worse now than they were 10 years ago. Oh my. This isn't healthy, folks. This is getting worse. You can probably guess my question. Why? Smoking more, definitely. Smoking more might be one. Stress might be one. By the way, any of you, actually, let me go back one. First question I should have asked, what's the pattern?
Part of the recent news is specifically related to white Americans relating to substance abuse, alcohol.
Could be substance abuse, could be stress, could be depression. Is it SES? Socioeconomic status? I don't know, show up there.
She was going to say SES.
What's that? By the way, the short answer is we don't know, and it's probably not one answer. And that was actually a point I'm going to come back to. When you show data like this, it's very easy to think you understand it, and it's very good to have hypotheses, but until you go and talk to the folks who live there, you really don't have a good sense of it. And this one, we don't know. On the other hand, this is a huge issue to the U.S. population. These are folks who are dying earlier than they've needed to. It's actually worse than that. Oh, I didn't show my next map. Okay, apparently I left it off. We actually are losing ground compared to the other industrialized country. We're increasingly looking at a third world country. We're just not keeping up. The question is, what do you do about it? Because you can analyze these till the cows come home, but ultimately you need to act. So what I'm going to do is talk a little bit about what we've been doing in Durham and then North Carolina and then the U.S. As I mentioned, things often start with data. This is, some of you have seen this, is an actual map of Durham from 15 years ago. It's everybody with hypertension. We have almost about a 97% data capture in Durham for quite a few reasons. But we actually just did cloud mapping, and then we overlay all the other issues, all the other resources in the community, churches, libraries, liquor stores, grocery stores, and you probably wouldn't be surprised to know, and our community certainly were not surprised at all, that they always have the highest rates of hypertension and stroke and diabetes, or where there are lots of liquor stores and no grocery stores. But actually, that itself would be interest, but what was really important is the community used that data to go to the zoning board and get a zoning variance in one of those food deserts and get a tax abatement so they could bring in a full-service grocery store that would hire members of the community using that tax abatement. So that was, you can use this data with your community in powerful ways. What you do is, as you do that sort of engaged work, is you start putting together coalitions, folks like in this room and like the one who was here before. It's got public health, healthcare, business, educators. Health is more than healthcare. This is actually from Roderick Johnson Foundation, County Health Rankings, saying you really need everybody around the table because there are multiple perspectives to this. And one of the things that we really encourage, especially as we do healthcare reform, is that we get those stakeholders around the community and we share perspectives. This is the sort of actual map, not prettied up like the last one. This is a social network analysis of Durham County done by one of our partners organizations. We're 270,000 people. We have about 1,000 nonprofits in our community. Whenever 3 or more gathered together, we form a nonprofit. And then somehow we have to coordinate all that. So it turns out the major coordinating groups in Durham are the health department and Duke. Actually, we're the biggest employer, and we've decided part of our role partnering with our community, and we'll talk more as we go about Medicaid, is actually helping coalesce those partnerships so we work on things in a coordinated way rather than separately. And we use this sort of social network map to drive it. We also use research, and research is something that in many communities is not always a good term. I'd point out that we're increasingly changing some of the language about this. This comes out of the National Institutes of Health, the NCATS, the group that actually funds these very large Clinical and Translation Science Award. And this is actually the language from last year about what you have to work on to apply for these grants. And it says that if you're going to have one of these grants, and Einstein has one, then you're expected to work with local communities, including disease advocacy groups, local health providers, and community-based organizations. That's a condition of the grant. You have to spell out how you're going to do that. You have to show how it's going to be integrated into the whole research spectrum. By the way, the other partners are expected to be clinicians at healthcare facilities, any of those in this room, and in the community who are integrated into the Research Enterprises active partners. We're trying to change the research paradigm to say it's not researchers and subjects, it's communities and stakeholders working together around the issues and needs of those stakeholders. And that includes specifically community practices and absolutely includes communities. So what do you do when you do that? So some of you have seen this before. Let me just mention in Durham, where we manage Medicaid, have been doing it for about 20 years, actually out of the department. We've been looking at care redesign for some time. This sort of program that we've discovered actually works. This is actually a request from our senior housing community. We wanted to know what we would do about seniors who were living in Durham. And I'm a family doc. I love actually taking care of older folks. And what I didn't realize is that across the street from one of my sites, this is a little embarrassing, is an elderly high-rise, 350 folks. Average age is 70. I'd never been in it, by the way. I've done home visits, I've done a lot of OB, but I've never actually been in that housing project. Average number of major medical problems was over 10. We use medical students and public health students and nursing home students to do a sweep. 44% had a major major mental illness, all homebound, 84% African American. Low literacy, many of them didn't finish elementary school. Average income was $7,000, 25% for rent. They had to live on $5,000 a year. Okay, folks, did they eat on weekends? Anybody? $5,000 a year. How'd they eat? Meals for Wheels is Monday through Friday. And the answer is they didn't. So this is, we got low income, low health literacy, major psychiatric comorbidity, geriatrics, difficulty mobilizing. They were in and out of the ERs. They basically ran out of meds and then would go to the ED. What in the world would you do with that? Some of you know this story. Anybody who doesn't know it? It's now being replicated around the country. I mean, it kind of sounds hopeless, doesn't it? Oh, it's not. Okay, let me go on. So what we did was actually ask people what they wanted. Now, there's a radical idea. And they said, well, you know, with all due respect, Dr. Michener, but, you know, it's really hard to get to your office or your offices because we have to arrange a van in advance, and we're in walkers. It's hard to get down there. And if we're late, actually, I won't embarrass you guys. I'll just say if they were 20 minutes late in our office for that appointment, what we do? We told them to reschedule. So we didn't see them very often. So what we did was actually work with about 40 partners, including our Center for Aging, Foreign Psychiatry, Area Mental Health Agency, Health Department, of course, Social Services, our FQHC, as we decided to try and do what people wanted and actually put physician assistants, nurse practitioners in the housing projects, starting with one, backed up by one of our faculty family docs and a geriatric social worker, and just go door to door delivering primary care on behalf of their primary care provider. Now, we did require the patient's consent, the people, clients, and everyone did except one who's hallucinating. We did require all the primary care, all the practices consent, and every one of them did. Every single practice, Duke non-Duke, agreed to let a PA or NP they've never met see their patients. The reason was they didn't see them anyway. They said, if you can do better, go for it. So we actually started, and the outcomes stunned us, and I'm still reverberating on this. So here are outcomes at a year and a half. Ambulance costs down 50%, emergency room costs 40%, inpatient costs down 68%. That was days and costs. Now, for those of you who heard me ask this question before, be silent. But, okay, for everybody else in the audience, give me anything that will reduce inpatient utilization other than death by 68% or more. There is one. It's not flu vaccine. It's not Pneumovax. Anybody? Anybody with public health training? Preventive medicine training?
Hand washing?
You mean? Antibiotics? Oh, that's a good one.
Hand washing.
Hand washing. Oh, no. No, no. Nowhere close. No. The only one we can find is a polio vaccine. So it's not the same. Polio vaccine keeps you from getting polio. But that has that sort of impact on hospital utilization. What we got from that is, you know, how you deliver care has an impact as great as some of the most famous public health interventions of this century. Wow. But there's a second story, because when we looked at the hypertension and diabetes control, this group of low literacy, minority women with almost no money had health outcomes of diabetes and hypertension control that until recently were better than the Duke faculty. So not just that we cut down the utilization, we actually helped them improve their health outcomes. They actually got feeling a lot better. Didn't save any money because they started actually taking their prescriptions, which is why they're doing better, and the home health care cost went up. So net, no, it was a complete wash, but boy, what a better outcome. So it's not just you can do better saving money at times, but you can also actually improve health outcomes. Some of you know this, I'd add, we did have a secondary problem of folks actually started feeling more energy and they started racing their go-karts in the hallways and turning them over and crashing into each other, and we had a whole bunch of secondary injuries, and that's a whole nother story. No good deed goes unpunished. But the point of this is this issue of listening to communities, getting the data, designing interventions actually proves to be a scalable method. So here's asthma. We had a meeting earlier today in this room about asthma, but here's actually the data for our neck of the woods. We started a program in rural North Carolina, including the school nurses, all the providers. Adding the school nurses made all the difference in the world. And pretty soon we're at a 65% reduction for asthma just in our region. We scaled that up across the state. North Carolina, admissions for asthma for kids with Medicaid are down 65%, and they've stayed down. So, I mean, 65%. So these sort of coordinated interventions with community partners, everybody in, start to have really substantial differences. And you got some similar programs here in the Bronx, as I learned today. But it's not just asthma. It's not just one disease where we now are reporting out because of our we're building capacity with our medical homes around community health homes, is that actually we can reduce all-cause admissions. So actually we've been able to systematically reduce our admissions of the people who are in our coordinated care models compared to our control groups. That's pretty substantial. It actually has hundreds of admissions per year. In fact, we laughingly say the best way to avoid a readmission is not admit them in the first place by keeping them healthier. So it's just been stunningly growing. And these have been scaled up. Here's data from, actually is Boston Children's to work with its local community, and they're 80% down at 1 year reduction in total admissions. So these sort of coordinated programs scale. Actually, we heard today about a program that by self-report is actually a little bit better than that. This is actually claims data. I really believe it. Boy, look at the groups that are doing this. They got medical legal partnerships, child care. It's not just housing, inspections, environmental assessment. These are multiple stakeholder engagements to drive this sort of substantial change. They're incredible. And it does save money, by the way. So my department runs Medicaid for 7 counties. We have access to the data. We're held accountable for health outcomes. And this is the GAO audited data showing that we took us a while to figure out what to do. We made a lot of mistakes, and then we progressively, systematically been reducing total healthcare costs by hundreds of millions of dollars per year. These programs work well. This is part of the reason why there's such a push for the medical home model. But I point out the model we're using here is actually more advanced, which is much more community engaged. So these examples actually got quite a bit of federal attention. It led to an Institute of Medicine report on integrating primary care and public health, and then to the playbook, which I'll talk about in a minute, and then to actually a scale up with a whole bunch of funders, the Bowman Foundation, Colorado Health Foundation, Kresge Foundation, Robert Johnson, saying, let's try doing one prospectively. Let's actually give people money ahead of time and see if they can do something like that prospectively. The Catholic Hospital Association predicted nobody would be interested in doing that. Our requirement was it had to be led by a community agency, a nonprofit. Governmental public health had to be a partner, and we had to have a health system as a partner, and they had to match the grant award. Grant award was $250,000, so you had to have 3 partners. And they said nobody's going to be interested. I mean, why would a hospital pay $250,000 to a community group to do this sort of work? I said, well, let's see what happened. We blew through 2,000 people on the webinars on that. Right before Thanksgiving, we had 337 applicants and actually 18 awardees, one of whom is here. One of our strong housing project focus. But our point is the interventions need to be bold, upstream, integrated, local, and data-driven. By the way, we're closely being tracked by CDC, CMS, and HRSA to see what works in this. These are the sites that we're actually have the interventions in. There are quite a few in Colorado because Colorado Foundation put in some serious money on this. But just trying housing, we're trying food deserts, food dev, doing that violence prevention in Boston, and I think it's in Salinas. Just saying, can you make a difference? We're just getting the first year report outs, just got them. And we're finding actually that you can make this difference, enough to feed back to CMS. So actually, make sure I didn't slip the slide. Well, I think I'll get to it in a minute. So it's catching the attention of the federal policymakers. So this is actually a August 2016, so pretty much off the press, review of population health and the work of the states have been doing, saying, you know, there's continued opportunity for interagency collaboration. Where they see that happening in states and cities is if you can get those interagency collaborations, you can really link health system reform and population health and make a difference. And this is actually going back to Centers for Medicaid and Medicaid Services, saying we need to focus more on these multi-stakeholder collaboratives because that seems to be driving the change. And primary care is absolutely essential to the core of that. So let me turn to the playbook. I mentioned we had the Institute of Medicine report. We've been doing with funding from the Beaumont Foundation is actually doing listening sessions, getting examples from the state health officers, CMS. We've also been doing all the big cities, all the small cities, NACHO, National Association for City County Health Officers, and actually looking at the examples that people give us. We work with CDC to analyze them. We write them up as concise stories, extract the key elements. We're over 250,000 users at this point. Page views over 50,000 users. Some places have thousands of users. And then we've been going around the country talking to folks about, you know, there's a method to this. And increasingly we're getting requests from overseas too. So we've done 24 countries. And we just partnered with the World Health Organization to build it up. But what we found in doing all these is you got to have the data. You got to have the health system. You got to have the community. But the hardest part of all this is what Mike McGinnis pointed out. It's actually about folks who bridge, the ability to see from the community, from the public health, from the medical perspective. It's that leadership. And when we looked across the whole country, if we could find a leader who had some vision of the future, we could find success. And we found that leadership, it didn't matter. Nothing worked. So I really applaud and compliment this group for your leadership. I've really been impressed with what we've heard in the Bronx. And before I stop, let me just point out where we're going is really around health, improving health for all. It's actually about integrating healthcare, public health, and research. And this, by the way, this slide is slightly modified from John Auerbach at the CDC, saying this is really the future for all of us together. Let me stop there and see if there are questions, and then I have another slide, which is back for the who can figure out the pattern. Actually, I have 2 slides. Questions, comments, disagreements?
Well, I'll start while people sort of formulate their questions. But one of the things that I noticed, you mentioned that you were able to take the asthma work that you were doing in Durham with 65% reduction in ER and admissions, which is truly amazing. But even more amazing was the second statement that you had managed to then disseminate that across the state. And I would venture to guess that that is not a typical result. That most of the time, what's done in one community is not successfully disseminated across a state. And so you did something that made that scale up work. And can you talk about that a little bit?
Sure, but I like to turn it into questions, because we have a lot of folks doing this sort of work. If you were in a system in which you had to improve health outcomes and save money, and there was a place over there that figured out how to do it, what would you do? Go talk to them. So what we did, our dissemination strategy was very simple. We shared the data and we said, look, it may not work for you, or you may need to do a different path, but here's what we did. And then it's not, here's the answer, you do it, it's here's what we achieved. It turns out the idea you can do it is the hardest barrier. And then we talk. It's a very humane activity, and we share examples. North Carolina is a loose federation of 13 networks. We share stories right, left, upside down, and backwards. Yeah, and it's a friendly competition. So if somebody figures out how to do it better, we all want to match it. It's literally that. By the way, in Boston, we didn't tell Boston what to do. I mean, guys, I went to school in Boston. You don't, my accent, you don't do that. We just said, hey, look, we had 65%, actually 68%. They said, and doggone it, they didn't break it, that record. They still hold the record. So it's really about making it clear it can be done and talking about the methods and letting folks figure out what works for them. There's nothing more. That's the secret sauce.
Yes. I am curious if you could share with us what is your experience and experience of other high-power individuals working at the top, deciding policy issues and so on in terms of primary care and population health. I think that there is a blindness or deafness about the current socioeconomic environment of primary care. So the pressure is for productivity. The research documentation really justifies and documents the burnout of primary care physicians. And there is lack of protective time to think community, not only to do thinking about research. So I would invite you at your next meetings to call the IRS and to call Homeland Security to address these issues of primary care.
Could everybody hear that comment? I mean, I couldn't agree more. And just to be clear, North Carolina is not a Medicaid expansion state. We have a Medicaid waiver, 1115 waiver, and the issues you described. I mean, we have Epic. We spend more time documenting than we do talking to our patients. It's a very real issue to us. The question is, how do you change that game? And for all of my colleagues who have tried to address it head on, the answer is we haven't gotten a whole lot out of that other than headaches and bumps. So this is about changing the narrative, changing the discussion to say, rather than arguing about primary care needs to do, how tough it is in primary care, which we've been arguing for 20 years, it's saying, what is it that we can do that would matter to the people we serve? And that's actually, and this is now, I'm going to actually address the policy side of that. That has meant helping family medicine, pediatrics, and internal medicine, saying, guys, we actually are here to serve, and we need to ask the question of whether we're serving well. And the extent to which we can do better, and I showed you several examples, I have more, then maybe what we ought to do is refocus around not our problems, but the problems of the people we serve, and how we can be more effective partners with them, and then let the policy follow. And in fact, that's what we're finding, as we find better ways of delivering health care. And remember, I'm a family doc at Duke. That the health systems will follow for the pure reason of it works better, and it saves money. And we're finding, actually, just to add that point, we're moving at Duke. We have, I forget, 140 family docs now. There used to be 5 of us. We're actually expanding rapidly, and the reason is simply because our communities know it can be done, and expected. And we're having to redesign how we train primary care docs in order to learn how to partner effectively with our communities and do our own innovations. What I showed you worked in Durham. You need to figure out what works in the Bronx, and you're doing that, and you need to do it. Is that a long-winded answer, but I address your point? Yeah, we can talk later. Okay, we got another question.
Hi. How, in the work that you've done in North Carolina, how do you engage frontline staff in work like this? And while policies and infrastructure is absolutely pivotal, engaging frontline staff, inclusive of physicians, your clerical staff, your nursing staff, how do you get them engaged in making sure this work is sustained?
You mean the people who live in the communities that our patients live in?
Kinda, yeah.
Yeah. It's a great question. How do we engage staff? And part of the answer is making them part of the solution. So when we have meetings, and this has been a bit tough for us because that means the idea of faculty meetings or clinician meetings that we actually need, if not everybody in the staff, because somebody has to keep seeing, but we try to get everybody in that room, everybody in the care team engaged in the problem solving, because it's often the folks in the front desk who know what's really going on. I'll give you a different story. Part of the reason I think that Just For Us program works in the housing projects isn't just that we're great docs and we go out and we have PAs and NPs there too. It's because it taps into the social network. So it's the lady saying, hey, would you check Mabel Smith? She was banging on the wall last night, and I think she may have been seizing. It's that informal feedback of people who know the community and know the folks in it that tells you what you need to attend to rather than waiting until people show up to see you. So having that regular feedback from folks of and from the community as part of your care team is essential. Let me stop and say that one more way, because I know I have a bunch of docs in here. We had a question earlier today about what do the communities and these care redesign folks need of docs. And the answer we're hearing nationally was not brought up in this room. The answer we're hearing is, first, we need you to be present. Now, being present means to be physically there and listening and not necessarily talking. So the first thing is we actually have to teach our residents and our faculty to be comfortable being present and to listen before we speak. Al?
Lloyd, this is a question. You've kind of had the high altitude, positive, progressive, innovative perspective, but at the current moment, it seems that most of the perception about the health and healthcare system is largely that the experimentation has failed, that the Obamacare is a disaster, and that the public perception is all focused on the problems that have not been solved rather than the progress that has been made. And I wonder if you could comment about how do you, and Drew Altman from the Kaiser Family Foundation just published an editorial in the Wall Street Journal about how the polls bear this out in terms of a third of Americans thinking that Obamacare increased the uninsurance rate across the country, and that the, if you will, the partisan debates have led to a very distorted perspective on where the healthcare system and the public health systems are going.
So that's a great question. I'm going to give a medium-length answer because it's not a simple question. But the Affordable Care Act has several sections. 99.9% attention has been around insurance and exchanges. What most folks don't track is that other sections represented the largest transfer of power from the Congress to the executive branch we've seen since World War II. It gives the authority to CMS to do experiments, try things, and if they are found effective, to scale them up without going back to Congress. That's enormous. I made the comment only partially tongue-in-cheek about spaghetti method. What CMS is doing is trying things. And you don't expect early in this that everything's going to work. Now I've given you a high level overview. I didn't tell you about the $1 million we wasted on our bright ideas of what to improve diabetes outcomes until we actually stopped and talked to the patients who told us none of those things were going to work, which we already figured out because we wasted the money. So yeah, a lot of things don't work. The key issue to me is figuring out what does and sharing that and disseminating it. And that is happening. Let me take one more example. How many of you know what MACRA is? Would you raise your hand?
Say it again.
MACRA. Medicare, oh dear, I don't think I can do it. Medicare authors. Medicare Access and Reauthorization Act. You need to learn about MACRA because that is a new federal regulation. It's in place now. It has broad support from both sides of Congress. It's not going away. It is shifting. They just came out with some of the new regs, but it changes how we're going to pay everybody. Anybody who gets paid for clinical services is going to be paid on much more complex formulas and increasingly on value-based care. So it's going to force us all through a very harrowing process of change. I think it'll continue to evolve. Again, CMS has the authority to do that, but I do think, let me frame it another way, I think this is the most exciting time in healthcare in 50 years. All the rules we've labored under that have driven us nuts are starting to go away. What the future is going to look like, we don't know yet. We're having to figure it out. What I'm excited about is that we're starting to find things that work better. And what I tell my residents and students is, guys, it took us 50 years to mess it up this much. You probably can't do worse. So help us figure out how to do it better because, I mean, look at these examples. And again, we have lots of them on the playbook site. You can do better. But what's clear is doing better requires getting outside the walls of your office, being present, listening to people, listening to your staff, and designing care in ways that actually meet the needs of people where they live and work. And I have to tell you that after 20 years of this work, if you have that in mind, you will succeed. And your patients and you will like the results. And any of you, by the way, one last bit, we teach this in our family medicine residency. We have to be good family docs and they have to learn how to do this. We had over 700 applicants for 5 positions this year. I mean, the idea that people don't want to learn this, well, maybe we just got only 700 in the U.S., but every year the number goes up. This is so, it's not just powerful, it's fun. It puts the joy back in practice. Oh, that was a long-winded answer.
So Lloyd, maybe I'll get one question in here. So this is NYC. We do research. We try to kind of use research. So what do you think is the role for research in kind of promoting?
Thank you. Question is, what's the role of research? I will give you an answer, 2 answers, one of which may get me in trouble. Maybe they both will. What we've been encouraging the research networks to do is partially to focus on the questions that arise during the course of practice, and you guys do that beautifully. But it's even more to look at the issues of the communities and how those research networks can serve as effective conduits for testing new models of delivery in the office and outside that actually make a difference in health outcomes and cost. And the practice-based research networks are just a stellar opportunity to test what works. We use our practice-based research in North Carolina along with our Medicaid network as a test bed to just try different things at different places, evaluate it carefully, disseminate those, write it up, get the word out. I don't think we could live without them, but they're driven increasingly by the needs of the community and the questions of the practitioners.
In terms of, everybody can hear me.
So in terms of, doing the research in the community, and you're saying, it's determined by the needs of the community, how do you find out what the needs of the community are?
So that's a wonderful question. Actually, what we practice and also teach is if you don't know the community, start going to the health department. Now, not every county or state in the U.S. has a health department, but that's a good starting point, and they will help you navigate. But we're also having to teach health departments what to do when a doc shows up and says, okay, I'm new, where am I needed? Then it's actually to talk to your elected officials and actually, how can I say this, to listen first about what the needs are and where the opportunities are, and spend a while learning the culture, the norms, the issues before you rush to help. So we do a very formal listening, but again, most communities have structures. I mean, Bronx, Lord knows, has structures and systems, and community groups been doing this for a long time. What we encourage is that for the medical groups to connect to those groups rather than create our own. You want to push back?
Well, I was hoping you would say you would actually go out to the community and speak to us. That's what I wanted you to say.
So the answer is yes, and. The issue is, what do you do if you're in how do you know where to go to listen? And I've been a community organizer a long time, and not everybody who comes talk to us about the needs of the community represents the full breadth and issues of a complex community. So I used to say that, and I've shifted a little bit to say, find somebody who knows the community who can help you navigate it before you talk to the first person who comes along. Okay.
So I have one more question. So you've shown us you've built a better mousetrap. I'm way back up here. Built a better mousetrap, and you've actually created value. So in light of the conversation about MACRA, how do you pay for this now, and how will you pay for it when we move to a value-based framework?
Thank you. That's a great final question. The answer is that with practice, you get to where you can improve health outcomes and reduce costs. That's value. So the concept here is the idea of learning communities, learning health systems, where with the impetus of MACRA, of DSRIP, of Medicaid reform, pick whatever policy lever you want, you're actually engaging with your local communities because they vary, and you're trying things. And actually, I would argue the role of academic health centers, especially their primary care departments, is to be that innovation lab with the community to test things. What works? And by the way, we're funded in part by our CTSA, partially by grants, partially by a hospital. Disseminate it, scale it up, because that's actually how you succeed under MACRA or DSRIP, is you'll actually figure out how to do this work. It is doable. So last comment is that what we've learned in doing this all over actually I don't have that, I showed this slide earlier. There are two barriers to success to doing this. The first is not knowing that it's possible. So one of the things I wanted to do is share with you is knowing it's kind of like running a mile in record time. You have to know that it's possible to even try. You can do it. The second one is the importance of language and culture and people who bridge those two, because you need bridge people to do this. It's not about healthcare. It's not about community health. It's not about public health. It's not about health. It's about all that. So you need to find bridge people who help you figure out that way. But if you've got that vision and you got willing to try some things and make some foolish mistakes and learn from it, and you got the bridge people, you will succeed. And based on what I've heard here today, oh man, you're already way ahead. Keep going.
All right, well, that's probably a great place to wrap up. I would like to extend my thanks to Dr. Michener for showing us the possible, as he would say. Before we wrap up, again, I just want to thank everyone for coming, and I want to invite you to go across the hall to the Grand Hall, where there are 53 posters that represent hard work of students, residents, investigators, clinicians, people who've collaborated with community, people who are thinking outside of the box, most of which has been done with very little resources, people really coming together and just being curious and trying to find ways to answer the important questions about how we're practicing and how we can reach out into the community. So I want to just take one more moment to thank my comrade, Paul Michener, for his help, and in particular to acknowledge Claudia Lechuga and Mariel Connolly, who are really the glue that hold together Nice Ring. They're probably out there doing work, so they can't even be acknowledged, but I want to make sure that they know that how much we appreciate their hard work. So thank you for joining us. We look forward to everyone sort of exchanging ideas around the posters and enjoying the refreshments. So thanks again for coming.